Welcome to Your Infinite Health. Are you getting older?
Are you feeling it?
How would you like to do that in reverse?
We're your host,
Dr. Tripp
and LeNae.
We've run an integrative medicine practice for 13 years.
Together, we have 60 years of combined experience helping clients.
We've helped tens of thousands achieve success in health and live longer, happier lives.
In this show, we'll cover peer-reviewed and evidence-based integrative approaches to creating the health you've always wanted.
We also share professional experience we see in the field every day.
So if you're ready to feel, look, and live your best life, you're in the right place.
Welcome to Your Infinite Health podcast.
Hey, Tripp.
Hey, LeNae.
I just went blank on jokes. So do you have one?
No, I don't have a joke today.
I mean, although I was in the car, I was taking Henry to music lessons, and Henry was has a deck of, well, I bought them, but he was reading them, this deck of Halloween dad jokes. And I think one of them was, they're really bad, but one of them was, what do zombies eat for breakfast?
Oh dear, I don't know.
Rice Krispies.
Oh, good.
He only read 3 and he's like, these are stupid. I'm putting them away. So, listener, you can hear our guest laughing. We have a special guest today, Tripp.
Oh, tell me.
I think the two of you are going to take over the podcast, and I'm just going to be sitting here not understanding either one of you because, and let me tell you why. Our guest graduated from the University of California, Berkeley with a degree in biochemistry and molecular cell biology. He earned his Doctor of Medicine in 1992 from the George Washington University School of Medicine. He contributed to virology research during his studies, and after graduating, he undertook a residency in neurological surgery at the University of California, Irvine Medical Center until 1997. And then he pursued a fellowship in spinal biomechanics at the University of New Mexico until 1999. He is licensed in California and Nevada and has spine practices in Orange County and Henderson, Nevada. A trained neurological surgeon, he specializes in athletic injuries and spine procedures and offers longevity and biohacking consultations. He's certified by the American Board of Neurological Surgery and is a member of several prestigious surgical societies. Since 2020, Top Doctor recognized him as a leading neurological surgeon. He also received Health Tap's 2022 Top Doctor Award as a top neurological surgeon in the U.S. And he founded Recelebrate, that's RECELL, focusing on anti-aging and regenerative medicine. The mission for Recelebrate emphasizes offering modern biochemical treatments and considering surgery as a last resort. Welcome, Dr. Jeffrey Gross.
Awesome.
Thank you so much.
That statement on surgery. Yes.
Well, it's so nice to meet you both. It's an honor to have colleagues like you, and hopefully we can compare a lot of notes today about things that stimulate each other as well.
For sure.
Awesome.
Really excited to have you on as well. And this idea that you're a surgeon that doesn't want to do surgery. I mean, how did that happen?
Well, it's not that I don't want to. It's that because there's a certain enjoyment in doing a surgery and having the great outcome, but really it's an invasive thing, as you know, and as they used to tell us in our residencies, you come to your residency and you learn to do surgery, and then you go into practice to learn when not to do it. So I've just really refined my craft on how not to do it. And one of those ways is to add more options short of surgery.
Right. So
that tends to be a trend now, I think, with certainly with stem cell approaches and exosomes and that. And I am just, I can't wait to hear some of your thoughts on what you've been doing, because it's that fascinates me, and certainly in central nervous system. Yeah.
Well, so how did your journey lead you into the stem cell approach?
Sure. And I look forward to sharing with you here what you're doing too and learning. But having practiced surgery of the spine and brain, but mostly spine for 25 years, I noticed patients becoming frustrated with a large gap between trying non-surgical treatments like therapies and anti-inflammatories and rest and flexibility and maybe even spinal injections, such as epidural injections, and maybe having some benefits, but not adequate benefits, whether adequate in the amount of benefit or adequate in the time of benefit. Leaving usually a discussion of, well, here are the surgical options. But unfortunately, those surgeries by and large haven't changed drastically in 60 years. So what we were trained to do is either make more room in the spine or stabilize the spine in a fusion surgery with metallic hardware or some combination of those two things. And those really haven't changed, much in a long time. And the outcomes of those surgeries are not always perfect. And patients are savvy now. So they come in and say, well, I'm not all the way better, but I'm really not ready for surgery. I can work and I can get by and I suffer, but I can't do what I want to do. Hey, doc, how about stem cells? How about this? How about that? So eventually,
you had patients coming to you and specifically asking for stem cells.
Yeah. Well, they were saying, hey, we heard this sexy word. It sounds good and it's been around. So I think, and I don't think they knew what they were asking for. And frankly, for a while, I didn't fully understand because there was a time where I said, well, it's really not part of what we're trained to offer, even though it's exciting research and I follow it also. And it wasn't until their frustration really became my frustration because I had this large group of patients for years I've accumulated who aren't ready for surgery, but they're bad enough. So about 5 years ago, I went back and said, I am going to stop going to the neurosurgery meetings, to the annual conferences where, we hear the same things and, and regurgitate the same material. And I'm going to change my direction. I'm going to take on some new education. So I went to some regenerative medicine conferences. I did training and education, and I started reading more literature in this area, and I got excited by it. And I see what is being done in other countries, follow-up studies on the clinical side for nearly 20 years. And then I became aware that just, it's slow here for various pressures. And I wasn't going to let that hold up my ability to offer good things to my patients.
Awesome.
Yeah, I think you have kind of a comparable experience, right?
Yeah, I guess I don't want this. I want to hear more about you, but I think as I transitioned into integrative medicine, and I actually stumbled upon a musculoskeletal prolotherapy meeting, and went and I guess just got fascinated by the mesenchymal signaling cell thing and exosomes and all that.
I forgot to put my disclaimer in. We can't say stem cells because the FDA doesn't want you to use the word stem cells. So we're not going to use the word stem cells.
No.
Okay, go ahead.
It's in all of our meetings, but at any rate, that fascinated me, and my philosophy is to try and, in our practice in infinite health, is actually to stimulate the body's repair mechanisms to do the work that they were already biologically destined to do, and that might be inhibited by some inflammation or some other things. And so that mindset, that philosophy, just happening to fall on that meeting, and the reason is because I wanted to deduct the meeting. My sister lives in the same town that
it was a work
the meeting was
trip.
being held in. So, at any rate, so fascinating meeting. Got the initial bug, and I just started reading. Went for it with the AAOM. Got trained. Spent 10 or 12 days just doing procedure after procedure after procedure, and just after that, I started having the results of prolotherapy in the practice, and subsequently with all of the other information with the exosomes and the mesenchymal stem cells, signaling cells and all of that, became more interested in seeing, well, this works so well in musculoskeletal, what about systemic disease? And so I followed that path now at this point, and have been treating, I've treated a couple strokes, I've treated some liver dysfunction, kidney failure,
Okay, now
these
enough
other
about you.
things. So I'm gonna shut up now and let you go ahead. So, yeah, I really, yeah, please. Sorry.
Bravo. I think we've converged. I think we have roundabout ways ended up in the same thing. And you said it great. Yeah. I mean, we lose our regenerative capacity that we're programmed with, because the accumulation of inflammation slows down our cellular processes, and and we need some help sometimes. So I think we are both on that same page.
Absolutely.
So curious to see, what kind of challenges did you face when you were transitioning and bringing in regenerative medicine therapies? I mean, if you actually had people, with some information coming to you and asking for this treatment, we're in an area where the information has been slow to get here, if you know what I mean. So we have probably a large challenge of re-educating and actually getting some pushback from orthopedic surgeons. So I'm, curious.
The surgical, community, yeah.
Well, I think when people were first asking me for things, they didn't really know what they were asking. They just heard about it. And 25 years ago, patients would come into my office asking for lasers. Something space age, something they heard about or saw on Star Wars. That didn't mean that it was the right offering or there was something useful, although there were large companies in this country that used the phrase laser in their name just to get the excitement and the buzz, even though they really weren't doing anything material with lasers.
Right.
So I also have the education hurdle, which I enjoy in some regards. But yeah, I mean, I do a lot of second opinions. In my career I have, and I still do. And the first opinions were like I was before I opened my eyes, and they've got the blinders on, and all they see is what they were trained to do 20 or 30 years ago by people who were trained to do the same thing 20 or 30 years earlier. Mm. So we have this relative lack of progression at least in the spine arena. So my bigger hurdle is economic, though, because I want to make this achievable and somewhat affordable for the average patient. And patients are very frustrated, as I have been for many years, with what is allowed to be called health insurance. Right. And I said that way on purpose because it truly doesn't insure as much as it needs to. So patients come in and they say, "Oh, I have great insurance." Okay, let's see. And then we test it out. And of course, they really don't. It's great if you don't need it. It's like auto insurance. So we have really worked with people to suggest, health savings account plans, because you can use that health savings account money for your health without someone telling you how to use it necessarily. And we have solutions, and we try to keep it very affordable. And really, most of what I do in regenerative space is a lot more affordable than the cost of surgery and the pain and downside and risks of surgery. So, and we're gathering some fun results, as I'm sure you have in your practice, with, and I say fun, but
exciting, transformational.
I don't have enough to publish yet, and someday I will. And we have before and after MRIs and things showing some wonderful things, and it's exciting. Yes.
That insurance, I could go off on that for sure. That's always a thing. People think that everything should be covered by their insurance. And when you're getting into integrative and regenerative modalities, it's not covered. And I've even had some conversations with patients who were trying to bill their company on the back end after getting procedures to get reimbursed. And I'm like, sorry, no code, no claim, babe. Doesn't work that way. And So that's been, kind of an issue as well. But those products are not cheap. I mean, for us to acquire certain products, it's a huge outlay. And so I think people should understand that it's not the doctor charging a huge profit margin on acquiring those products. They're still very expensive to get.
Agreed 100%. And even though the prices have come down and at least in my space, I'm going to use these words carefully as to not run afoul here. The cell signaling biologics are less expensive than the cellular, than a similar effective dose of a cellular product. I don't know if you've noticed that as well.
Well, the cellular, if you look at the nanoparticles, which are starting to dominate now, and rightfully so, the nanoparticles, one mesenchymal signaling cell can produce about 1,500 of those nanoparticles per day. And I don't know who the geek was that calculated that, but kudos to him or her. And so if you're doing that and you use, let's say 75,000 or 75 billion of the nanoparticles, which is an aliquot that is available and I use not infrequently, that represents in actuality 50 or 500 million stem cells. Okay, so the fact that people go to Mexico to do some of these regenerative procedures with the MSCs, actually they go down, they have their bone marrows done, they put them into, plate them and turn them into cell cultures to grow the numbers so they get to that 50 or 500 billion or 50 billion number, and then they re-inject those for the procedure. And I'm not sure if you're familiar with any of those locations or not, but at the same time, in actuality, you can take one of those aliquots of 75 billion, and it's the same amount. It's actually the same amount as that, having to go down, have them cultured, and all those things. So, yeah, I think availability is an important thing, and I think we're going to see that trend of decreasing cost. Hopefully, it'll become a little bit more aggressive than it is now. But yeah, I can imagine in the central nervous system, I'm not sure how much you use or that, but it's I'm interested to hear.
Sure. I'm enjoying this comparing of notes. I agree with you. I think exosomes are more efficient, more affordable, and potentially can be a stronger effective dose. And as we haven't mentioned here, and I'm sure we're going to segue into more nervous system activities, is exosomes are called nanoparticles because they're measured in diameter by nanometers, 10 to the minus 9 meters. And those are small enough particles to cross the blood-brain barrier and get into the brain and the spine. Whereas cells struggle to cross the blood-brain barrier unless it has problems. And they have to be either delivered directly into the nervous system, which requires, as you know, this is more for the audience, either a spinal tap or something even more significant, or those cellular offerings do produce exosomes, like you said. So the thing I wanted to go back and mention about cultured biologics or cellular products in culture is the culture is not a natural medium. Even though it simulates a natural medium, it is ex vivo / in vitro. So let's explain that. Out of the body in a lab.
Exactly.
So it is not encouraged of the natural soup, or in English and French class, we called that milieu, the natural milieu of the body's own growth factors and local environments, cellular environments. So we're not exactly 100% certain what a simulated in vitro culture medium does while asking it to encourage volume production. Do you agree with that?
I agree.
Okay.
100%, yeah.
Now, there's nothing wrong necessarily. We just don't know. So this isn't meant to discourage people from taking a trip to a different country for a large dose of cells or something, but you can receive here in the US wonderful regenerative care, whether you're in Louisiana or Nevada or elsewhere. You just won't see us advertising as robustly because we have to remain compliant, of course. Right. So they have a leg out of the country, has a leg up on that, but that's fine. In terms of the nervous system, as I've gone into regenerative medicine, I now treat more than the nervous system. And you probably have a wider experience in post-stroke neuro rehab and that kind of thing. Although I've addressed that. I've addressed traumatic brain injury, as I've read on your website. You do as well, and that's really wonderful because traumatic brain injury is known to have a very high neuroinflammation profile as the brain attempts to heal, as the neuronal cells and the supporting cells attempt to heal. So the regenerative approaches are so highly anti-inflammatory that it's a wonderful approach. And of course, the earlier you get to these things, I think the better they do. Is that what you've also experienced?
That's the same. Yeah, absolutely.
Yeah. And, we accumulate enough patients, we'll publish on this as well. But the problem is, we're always told, well, we don't have a double-blind study, The problem is, who wants to sign up for the placebo on this one, right? Nobody.
Exactly.
It's a study that may never be done. So
I agree with that. There are a lot of, it's particularly in an environment that is not subsidized monetarily. I think getting a cohort of patients to sign up for a clinical trial where they may not actually be treated is going to be virtually impossible. I can't imagine anybody wanting to sign the release form for that.
It'd be an interesting study, though.
Yeah.
Sad but true. Yes, it would be an amazing study, and not just for the brain, but post heart attack, autoimmune, or other hyperinflammation syndromes. These are ripe. These are ripe.
Absolutely.
So what's your best case study?
Well, the low-hanging fruit in general are the musculoskeletal anatomic elements like the knee. I'll call it the extremity joints, particularly weight-bearing joints. I think the knee studies are my best, and I have the largest accumulation of clients. We are doing lower backs, and I need more time to collect that data. I will tell you, I follow the protocol of Philippe Hernago, the French study with the now 17-year follow-up. They publish their follow-up every 5 years. And if I may, since I saw a puzzled look on your eye, I'll share with you in the audience why I follow the study. So Dr. Hernago is an orthopedist in France, and they took a population of patients who were recommended to have knee replacement surgery. So they had, we'll call it end-stage osteoarthritis of the knee, or what simple phraseology would be arthritis or bone on bone, even though it's really not 100% bone on bone. So, but people walk in and say, my doctor said I'm bone on bone. Well, let's see what that really means, right? So they took these patients who were already end stage, and they said, hey, before you do this surgery, join our study, if you like. And they signed up, I think it was 100 people, and half of them had bone marrow concentrate, so a cellular product from bone marrow. And we could probably use the words here because we're talking about a study, but so they used the patient's own stem cell concentrate from the bone marrow, which is a rich source, as you know. And half the patients received interarticular injections. And I know you know, but for your audience, that's in the joint where the meniscus and the soft tissues are. And then half of them received intraosseous or in the bone injections, just above and below the cartilage, in what's called the subchondral bone. And I follow that because at the 5-year mark, they had significantly wonderful results where both groups were able to avoid the knee replacement surgery. At 10 years, the groups started to stratify out where some of those patients with the intra-articular injection needed to go back and their knees failed.
Mm-hmm.
And then at the 15-year follow-up published in 2021, yes, they have a long-standing follow-up. There was a significant separation, and it was clear that the bone-injected group had almost low 80% preservation of joint salvage. Only a small 17% or something had to go back and be reconsidered for joint surgery. Whereas in the joint-injected group, only 20-some% were salvaged at that mark in time. Now you might say, well, if you fell out of the study and your joint failed, could you go back and do it again? And the answer is, of course, probably, but it wasn't part of the study. So they clearly defined that the party is in the bone. And I think the reason for that, and there's some writing on this as well, is that our own stem cells are in the bone. And those stem cells give nutrients and blood supply to the joint. In fact, when we were a fetus and even after we were born for a number of years, our body was creating that joint. And it was being created from the stem cells in our bone marrow, surrounding the joint. So we're tapping back into the original factory equipment by remanufacturing our own cartilage proteins, collagen, proteoglycans, chondrosoglycans, all these fancy biochemical terms that make up a meniscus or a disc. So I take that approach. So we're doing mostly intraosseous injections, and my best results come from my intraosseous injections of nanoparticle type biologics. And we get the initial anti-inflammatory benefit, which can reduce pain and improve function. And then over months, we get, we start to feel the regenerative benefits. So it's a 2-peak benefit. And we do have some pre and post MRIs where we've gone from grade 3 or 4 chondromalacia, which is wearing down of the cartilage. Grade 4 is the worst, right? That's the bone on bone. All the way back to grade 1 or unremarkable on the MRI. So
that's phenomenal.
So we're asking someone's body to tap back into that initial, find the blueprints and rebuild this structure the way you built it the first time. And it's almost too easy. It's wonderful.
It is. It's a phenomenal response. And that happens. I guess my thinking is that how invasive is that procedure from your perspective?
Well, compared to a surgery, it's nothing, right? But we do sedate people in a surgery center, injection facility. This is not general anesthesia. We do all the targeting ahead of time. I get very high quality MRI images with something called inversion recovery sequence, which shows us the bone marrow because the targets are in the bone marrow. And we then do the procedure under fluoroscopy, which is X-ray in a surgery suite, sterile conditions. They don't take all that long, maybe 10 minutes per area. And so we do sedate with some oxygen and a sedative so people don't feel it. Because we do have to go into the bone, and bone can hurt. And we have the right needles for that and a very small drill. And people are sore for a day or two, but no downtime. We want them up and around, stimulating the mechanoreceptors and the good activity that comes with that, the biologic activity that comes with that.
No downtime. They can go back to work. Come see you in the morning and go back to work. Because that's what everybody wants to do.
You're in a place where people travel. It's a destination. We're in a place where people travel. It's a destination. So, people that fly here, we like them to stay for the weekend and enjoy what a nice dinner, get a show, enjoy what Las Vegas has. But we do have people on Friday. Some of them we have them go right to the MRI center. We set it all up. They come right to us, and then we take care of things. Most of the work is done ahead of time remotely.
Nice.
Yeah. So I'm wondering, because with the prolotherapy, I think my technique has evolved over the last 8 or 9 years, and I think I do I know the results I get are really excellent, and I guess I haven't trailed all the numbers or anything, but at the same time, I don't do just the intra-articular and that I think many doctors that are doing injections with nanoparticles or whatever, they're doing single injections, and a number of the studies that are out there are single injections. So prolotherapy being what it is, I do inject all of the insertion of the ligaments on either side, the collateral, laterals, and all of that. And I'm trying to maintain. And as I do that, I'm actually hitting the bone. I'm probably not going as deep into the bone or aiming at the areas where you focused on getting the cellular deposition there. But I think my results have always been better than those studies that are published, and I was wondering why, and I'm wondering if that's a component of it, because I tend to kind of overuse the product to get a good result, and I like, and the patients have really appreciated those results too, bone on bone or less severe.
Yeah. I have a colleague who also does some prolotherapy and some regenerative and on the West Coast. And he has said the same thing you have just said, that the enthesial attachments are the key for him. And he also has enjoyed good results with use of nanoparticles and other prolotherapeutic agents. But he has told me that prolotherapy is usually a multi-pronged treatment. You have to go more than one time. And if you look at some of the earliest, if you think about it, prolotherapy is a regenerative stimulating activity. And then if you were to move up from there, platelet-rich plasma would probably be in a similar realm. And PRP or platelet-rich plasma requires typically 2 or 3 sessions as well. Mm-hmm. It's only when you get up into the next realm do we have a quantum of probably enhancement of the dose activity where one and done can make it happen. Not in every case, but hopefully.
Yeah, I find with my procedures now, I'm probably using a Wharton's jelly-based derivative or exosomes or nanoparticles. I will have maybe 2. I have rarely had to go to 3 procedures. 1 or 2 is the kind of the mainstay at this point for knees, backs. Shoulders tend to be a little tougher, but always much less than the classic prolotherapy with dextrose and irritants. Those are 6. PRP actually is, I could rarely do a knee with less than 3 PRPs.
Yeah.
Well, and that PRP hurts.
Yeah, that stuff is irritating.
It does.
Painful. Definitely like the Wharton's jelly approach better.
Trip, you have an interesting observation I want to shed some light on. I have it too. Lower extremity joints, weight-bearing joints, tend to improve faster than shoulders and upper extremity joints. And I think it's because the weight-bearing stimulates the bone marrow and the activity in the lower extremities. We rarely get, you're really not weight-bearing on your arms unless you're doing a lot of walking on your hands, right? So... Right. And in fact, you made me think, because I really look at bone density testing on a lot of people to give me a sense of their marrow integrity, which is a clue of their stem cell population in some ways. We don't do testing often, bone density testing of the arms. You do the spine, you do the hip, usually, right? Those are the 2 classic ones. Mm-hmm. And maybe we would get an earlier diagnosis of bone density declining if we looked at the upper extremities also, and we did something. So parenthetically, at least theoretically, I believe that IV nanoparticles would stimulate bone density, and in a more logical way than some of the bisphosphonates and other
that has
currently.
I'm sure you're aware of that already with the IV injections of exosomes of nanoparticles does actually increase bone density. So I guess the correlate would need to be finding what the bone marrow is doing at the same time and seeing if there's activation there or what. Mm-hmm.
Right. No, it'd be a great study to do a bone marrow biopsy and then do the treatment, then do the bone marrow biopsy to see what we have. Or you could probably just do it by cell counts before and after, just peripheral cell counts, at least for some concept.
I do have a question. Do you have any experience with the using adipose MSCs or?
No, I'm not a fan. I'm a purist, and fat tissue is by definition inflamed tissue, and I don't want stem cells bathed in a paracrine environment of pro-inflammatory cytokines. Now, I threw out a lot of medical words there for the audience, but I don't want them bathed in a stimulation of inflammation. I want the most anti-inflammatory population of cells I can get.
Gotcha.
What about you?
Well, there's one study out that came out, it was about a year ago, I guess, or a year and a half ago, that I happened to delve into, and they actually did a comparison between the bone marrow, and these were the single injections, right? It's not not doing the subchondral or prolo. It's basically a single injection into the joint. And they showed superiority for the adipose, for the parasites, the mesenchymal stem cells for the adipose tissue. And it's much harder to acquire. Obviously, there's another procedure that's involved. You have to do the separation and all that, and so it's more cumbersome, certainly, to use in a clinical setting. So that's why I delved towards the Morton's jelly and the umbilical and resources that we have available, because they're readily available. Yeah,
I agree with you. I think when you use Wharton's jelly, you're probably got some nanoparticles. You've got amniotic constituents. You've got elements of extracellular matrix, which is now potentially an element that helps bind the nanoparticles. So it's sort of the all-in best product, perhaps. We're learning more about what's in these things and exactly what they're doing, and we're just getting better at it all the time.
Yeah.
Speaking of learning more, what do you think the trajectory is for regenerative approaches and these things going forward?
Well, I think economical and political, it's a wave that can't be stopped, and it will achieve a true credibility once big pharma puts money into it, and they're starting to. And
so they can patent it and make money off of it.
So they can, well, of course, yeah, and then they'll, the government will follow with them. I'll leave it at that, so I don't get buried in the desert somewhere. and then it'll be, improved. There's quite a bit of, silliness here, right? You have all these procedures are not approved for claims, including PRP, but some insurers pay for PRP. So it's ridiculous how they look at things. But we'll just have to continue doing the right thing. On the science side, I think we're going to have more cellular offerings and more nanoparticle offerings, and the nanoparticles will go from generic to designer. You'll have some that are better for, musculoskeletal. You'll have some that are better for glandular tissues. You'll have some that are better for general anti-inflammatory processes. And it'll just get more and more refined.
The question that begs, however, is that, and that's pharma's already using those things in oncology, and they're trying to do the use that to cross the blood-brain barrier for metastatic disease in the central nervous system and all that. And they're actually, from my little knowledge that I have, I think they're actually looking at trying to focus certain of the growth factors into the exosomes so that they can be, like you said, focused to be better for one type of administration or the other. The question that begs is that is that better than using the Wharton's jelly or the exosomes derived from the umbilical cord or the placenta? And that's a question I think will probably not be resolved either. You have all of the the microRNAs and all of these things, and if you're isolating one or two growth factors into those nanoparticles, you're missing all the other environment that's in there and all of the other potential stimulations, just like culturing in vitro and in vivo, which is I suspect that with the cost of these products and what the cost will be after pharma continues to develop them, I think we still may be better served using the human product.
I think I like the way you think. I think that there's a known natural balance that's already worked itself out through millions of years, and it's hard to play with. And I didn't mean by designer exosomes that for some reason it would only be a single stimulating growth factor or profile. It would be in addition to boost a certain area. But you're right. When you boost one area, another area could overcompensate. That's the nature of cellular pathways. We have all these yin and yang and control factors, kind of like the way the nervous system works,
Exactly.
So
cool. So what guidance, wrapping up here, what guidance would you offer somebody who's considering regenerative medicine? Like, what are the questions they should ask? How do they know if they're going to get the best, treatment?
Yeah, well, people should get multiple opinions. They should get an old school opinion from someone who's not trained in regenerative, so they can see what most people face. And then if they're intelligent and enough to seek alternatives, they should do their homework. They should see what's out there. They should at least get one, if not multiple opinions, because many of us have a different approach through regenerative medicine, and they should compare any studies that are existing or what studies we're drawing from when we offer something. They should look at the ease of delivery. They should look at the source, like you said, and the cost. I think those are probably the factors that most people look at when they talk to me, or I suggest they do. Most people say, I've looked at everything, and why not try this? It's not that expensive. And if it works, then I've avoided a surgery, at least for now.
Very cool.
And you always have the surgery in abeyance. I tell that to my patients too. You set that aside, but it's still available if the regenerative approach doesn't yield fruit.
Yeah, we haven't burned a bridge. If you have the surgery, though, you have burned a bridge. Going back into regeneratives now has a whole different concept. Now, and we have had patients like that, but we're not addressing the same issue that we're addressing something else.
Right.
Fascinating stuff.
Anything else that you would like the listeners to know?
Yes, the Kool-Aid that that for decades you may be hearing it may not be the best answer. Think outside the box. Do what's best for yourself. Don't let the payers, the insurers, tell you what's right and not right just based on what they will or won't pay for.
I like it for sure.
That. Excellent.
Where can our listeners go to find out more about you?
Well, I have our name is Recelebrate, as you mentioned at the outset, and that celebrates renewal of your cells.
Nice.
So you can look us up online. It's our website is recelebrate.com. We're on all the social channels, or most of them, I suppose: Instagram, Facebook, LinkedIn,
All the places.
Pinterest, TikTok. Oh yeah, we got YouTube.
All the things. And listener, we'll post links somewhere around here so you can connect with Dr. Gross. All right. And I think we're about out of time. Thank you so much for sharing your wisdom and expertise with us. I hope everybody found it valuable.
Well, I appreciate very much your experience and what you're doing. And I love that we have great overlap, and people reach out to me, from all over. And if they're anywhere closer to you, I'll be sure to give your clinic a shout out as well.
For sure.
And happy to be collegial going forward in any way we possibly can.
Love it. All right. All right, listener, thank you so much. And until next time.
Thanks for subscribing to Your Infinite Health. I'm Dr. Tripp.
And I'm LeNae. Until next time, feel it, look it, and live it.